Good evening, Dr. Bindu. I can see Dr. Neha, Dr. Seema Rastogi, Dr. Sudeepa, Dr. Ruchita, Dr. Sheetal Gupta, Dr. Ranjana, Ranjana Jha, Dr.
Namaste,
Madhav.
madam.
Good evening, Ranjana. खुश रहो,
Good evening,
खूब
Ranjana.
खुश
Good evening,
रहो,
good
खूब
evening.
अच्छे से रहो. Yeah,
अच्छे से.
we are live on YouTube, and so we are going to do this program once again, Dheera, which is a flagship program of Dr. Shanta Kumari, President, Federation of Obstetrics. Oh, good evening, Dr. Nandini. So you are here now.
Good evening, Dr. Nandini.
You are the one who has to start the first module. So I think you can start right away if you are prepared. Are you prepared?
Yes, madam.
Can you share or should I share for you?
Please share the slides, madam. My sincere apologies. I got late. Our first presentation is Violence Against Women, an Overview. Sincere thank you to all those who have helped collaborate on this project. Team Dheera Obgyn Gyne Core Group contributors to the PowerPoint presentation. Dr. Shanta Kumari, Dr. Kiranmay Devi Naini, Sir Ajay Bharadwaj, Dr. Vindhya, Dr. Ramani Devi, Dr. Rakhi Dhawan Singh, Dr. Deepa Mukundan, Dr. Anita Sabarwal, Dr. Jyoti Banglowala, Dr. Rohan Palshetkar, Dr. Krishan Men Gupta, and Dr. Aruna Suman. Gender-based violence put your responses in the chat box. There are some questions, and we would like to have your responses. What forms of gender-based violence are experienced as women and girls? I would like you, previous slide, madam.
Previous one.
Yes. I would like all of you to put some of the responses in the chat box. Where can women and girls experience gender-based violence? Which age groups may have gender-based violence? So these are three questions. Kindly write your answers or in the chat box. Thank you. I can see some of the responses in the chat box. Thank you for your responses.
Should I go to the next slide?
Yes, madam. What do we understand by violence against women? Violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. Violence against women encompasses, but not be limited to, only physical, sexual, or psychological violence, family, community, perpetrator, or condoned by the state wherever it occurs. And what are the types of violence? The types of violence can be physical violence, psychological violence, or sexual violence. In physical violence, we see patients who come with injury of kicking, biting, slapping, beating, strangling. And in psychological violence, preventing a woman from seeing family and friends, belittlement or humiliation, economic restrictions, violence or threats against cherished objects, other forms of controlling behaviors. In sexual violence, there can be forced sex, using physical force, threats, intimidation, forced participation in degrading sexual acts, denial of the right to use contraceptive, or measures to protect against sexually transmitted diseases.
Should I go next?
Intentionally inflicted injuries are often disguised as accidents. And sometimes women are seriously injured, and in some cases, cases die as a result of their injuries.
Should I go to the next slide?
Next slide. So these are the intimate, these are all the prevalences which are present.
It is the prevalence rate of the intimate partner violence
Intimate
by
partner
WHO.
violence, physical and or sexual violence by an intimate partner in their lifetime in South Asia. So in this slide, there is 16.3% of women in the Maldives, 25.1% of women in Nepal, and 24.5% of women in Pakistan, 20.4% of women in Sri Lanka, 14.9% of women in Bhutan, and 28.8% of women in India, and 50.8% of women in Afghanistan, and 54.2% in women in Bangladesh. Tips of the icebergs. Gender-based violence is underreported. 40% of women experience gender-based violence previously disclosed to someone, but only 7% reported to a formal source. Regional variation 2% in India and East Asia to 14% in Latin America and the Caribbean. Violence against women, the cycle of abuse. So in this phase, the abuse starts from pre-birth. Then it goes, sometimes we see patients who are of infancy, then even girl adulthood, then adolescence. So there are phases of violence against women, and this is the cycle of abuse. So this can be in the form of trafficking, honor killing, partner violence, marital rape, dowry abuse, murders, abuse of women with disability, rape, sexual harassments, forced prostitution, and pornography. And others could be forced pregnancy, acid. This all you see in adolescence. And if you see from the pre-birth, if you start from pre-birth, it is sex selective abortion, effects of battering on pregnancy and childbirth. Then it goes to infancy, which is below. You can see one circle below. In infancy, you see fetal infanticides, physical, sexual, or psychological abuse. 20% of women experience child sexual abuse. Then in girlhood, or there can be child marriage, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, and pornography. Then in adolescence, as I have already talked, there can be trafficking, honor killing, partner violence, marital rape, dowry abuse, murders, abuse of women with rape and sexual harassment, forced prostitution, and pornography. And there can also be forced pregnancy, acid throwing, and date rape, economically coerced sex, incest, sexual abuse in the workplace. So these are the different types of violence which a girl or a female experiences during her life. 1957, women in Pakistan killed in the name of honor between 2003 and 2007. 11.4 million women trafficked globally. 30% experience intimate partner violence, and 7% sexually assaulted by someone other than partner. Ma'am, next slide. So what are the different types of health impacts of gender-based violence on the individual? So these impact can be physical, or in the form of acute physical or chronic physical, or it could be reproductive. So in acute physical, we see injury, shock, disease, infection, weight loss, gain, regressive behaviors, start from 0 to 9, not eating or eating all the time. Now, in chronic physical, it can be disability, chronic pain, gastrointestinal disorders, eating disorders, sleep disorders, and chronic fatigue. In reproductive, it can be miscarriage, unwanted pregnancy, unsafe abortion, sexually transmitted infections, including HIV, menstrual disorders, pregnancy complication, and gynecological disorders. Next. So effects beyond the individual survival. So what are the effects? So effects on children of women who experience abuse: higher rates of infant mortality, behavior problems, anxiety, depression, attempted suicide, poor school performance, physical injury or health complaints, experiencing or perpetrating violence as adults. So effects on family. So what are the different types of effects on family? Okay, there can be fractured family relationship. There can be safe care if abuse happened in the home. Then housing instability, co-occurring violence, poorer collective health and coping. Effects on community and society. So what are the effects on community and society? So cost of services incurred by victims and families, health, social justice, loss of education and potential development, and contributions by child as they become an adult. Perpetuation of violence in community, higher crime rates, and burden on safety and justice sector. So these are the different types of violences and abuse which occur because of the gender-based violence. Next slide, madam. Where and how do violence and HIV/AIDS intersect? Direct transmission through sexual violence, type of sexual exposure, presence of another sexually transmitted infection, degree of trauma. Indirect transmission through sexual risk taking. Violence is linked to increased risk taking, multiple partners, non-primary partners. Indirect transmission through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face of or threat of violence. Next slide. So in summary, this is the pathways and health effects. So what can happen? So this is intimate partner violence. There can be physical trauma, psychological trauma, stress, fear and control. So in physical trauma, injury, musculoskeletal, soft tissue, genital trauma and others. In psychological trauma, stress, there can be mental health problems, anxiety, depression, eating disorders, suicidal tendency. And there can be substance abuse, alcohol, other drugs. And there can be non-communicable diseases like cardiovascular and hypertension. Then somatoform like irritable bowel, chronic pain, chronic pelvic pain. So this is an pathway which is given. And in fear and control, there can be limited sexual and reproductive control, lack of contraception, unsafe sex. Health care seeking, lack of autonomy, difficulty seeking care and other services. Now this can lead to perinatal maternal health, low birth weight babies, prematurity, and pregnancy loss. There can be sexual and reproductive health, unwanted pregnancy, abortion, HIV, other sexually transmitted diseases, gynecological problems. So in this, they have given the incidence. In this chart, they have given the incidence. Next slide, madam. Though this is quiz time. State, myth or facts. The statement is intimate partner violence is more prevalent among poor women and girls. So the answer is myth. It is a myth. Studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends. Next slide. Second statement is majority of sexual violence against women and girls is perpetrated by strangers. This is a myth. Studies constantly show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. Other statement is, it is safer for a woman to leave a relationship with an abuser than to stay. This is a myth. Violence often continues and may even increase after a woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after separation. Next slide. Gender-based violence is a serious human rights, health, and developmental issue impacting survivors, their families, and health and development of entire communities. Next slide. You all must have done already the registration and the pre-test. And after the whole session, after all the topics are over, there will be a post-test and the feedback. And later on, the certificate will be awarded to the participant. Thank you.
So,
Thank you, madam,
thank
for
you.
sharing the slide, ma'am.
So thank you, Dr. Nandini, for speaking on this. It was an overview of what violence against women is and what are the types of violence, how the cycle of abuse goes on, and what are the myths about it. Now you have to do the second one, the second module, I think. So if
Yes,
you will
madam.
allow, I will share. So the
Yes, ma'am.
second module is approach to women. Okay,
Facing violence.
yeah. Shriman, if you can let the people who are in the waiting room enter, it will be a help because I can't do the both things together, sharing the slide and also letting people in the waiting room.
I'll check, madam. I'll check.
Are you there, Shriman? If you can see that people are
Yes,
waiting,
madam.
then
Yes, madam. I'll check. I'll check. If there is anyone in the waiting room, then I'll allow them.
okay. So you can start, Dr. Nandini.
Thank you, ma'am.
Hmm.
Approach to women facing violence.
So it is about
So,
how to approach the woman facing violence.
yeah, how to approach. So, why do survivors not seek help? Uh, Victim blaming attitudes of providers, fear of shame and stigma, fear of no confidentiality, inappropriate services or services that are not useful prioritized by the survivor, perceived impunity of perpetrators. Next slide, ma'am.
So there may be other reasons, and people who are watching can put their own reasons in the chat box, whatever comes to their mind, because this is about also improving the modules more and more people give the inputs. So these are the points we have jotted, but you can put it in chat box if you have any point.
Yes, yes. We will discuss it at the end of the session. Who can play a role to help the survivors and how? So all the people who are around us in the whole day, like family, friends, individuals, survivors, community, service, healthcare providers, all can help. Role of family, friends, and community. Recovery from violence dependent on extent of support received by loved ones. Health professional engage with family and discuss ways of promoting survivors' well-being. It should be discussed with all caregivers that survivor should not be held responsible for the assault. Child sexual abuse partners may experience anger, confusion, guilt, self-blame. Retrieved that it is the perpetrator who misused their position. Next slide. So, what are the role of healthcare providers? All women are likely to seek health services at some point in their lives. Healthcare providers are often trusted by women and serve as role models in the community. Violence is an underlying cause of injury and ill health. Role of healthcare providers: creating an enabling atmosphere and establishing trust. Speak to the survivor in a private space. Recognize her courage in reaching you as they have overcome several barriers. If the person has come to you, that means she must have gathered all the courage and then she has come to you. Recognize the dilemma faced by survivor in reporting violence. Do not label non-reporting to police as false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources, legal rights, so that they can take an informed decision. Role of healthcare providers: facilitation, demystification of medical procedures. The health professional should prepare the survivor for an internal examination. Explain the various stages of the examination. So you have to, before a patient is taken on the examination table, you just explain to her what you are going to do. Like you have to tell her that you are going to do the internal examination and just explain to her. Communicate the rationale for referral for X-ray, USG, age estimation, among others. So you have to explain to her that after the examination, what are the tests which are required for her, like USG pelvis or X-ray. Next slide. Role of healthcare providers addressing survival emotions. Emotional well-being. Recognize the survivor may present varied emotions. Encourage the survivors to express their feelings. Encourage survivors to seek crisis counseling. Access for suicidal ideation. So if a person is giving you, while you're talking to her, and if a person is giving you some depression sign or she's telling something, so you can just judge by her talk that is she giving any signs that she's having any suicidal tendency. Make a safety assessment and safety plan for her. Involve family and friends in healing process of survivor. Next slide. What you can say. So take your time, share only what you would like to share. I can imagine that must have been really hard. It takes a tremendous amount of strength to share what is happening to you. How do you think we can help you? You are not alone. So you have to make the patient very much comfortable. Then only she will tell you everything. Otherwise, she will not come out and she will not speak. And so first of all, you make the patient comfortable and you tell her that you are not alone. Next slide. So what are the practical approaches? So this is a mnemonic, SOLER. So S is for sitting position. So sit in a proper position. Then open posture, lean forward, then have an eye contact with the patient and be relaxed, and see to it that the patient is also relaxed. Next slide. Supporting gender-based violence survivors using the lives approach. So what is the lives approach? It is L is for listen what she is saying, then inquire, then validate, enhance safety, and then give her all the support. So S is for support. Listen. So use verbal and non-verbal means to show support and communicate understanding. Ask questions open-ended, focused, closed. Use good body language, posture, and eye contact. See to it that you have a proper eye contact. Avoid leading questions and compound questions. So learn to listen with your eyes, giving her your undivided attention, ears, truly hearing her concerns, heart with caring and respect. So whenever a patient comes, you see to it that you are giving her respect and then also caring for her and make her comfortable. Next slide. So this is slide of listen. So in listen, what you will do, what is do and what is you don't have to do. So how to act. So be patient and calm. Let the client tell her story at her own pace. So just don't interrupt. Let her talk first. Give her some time. Let her speak what she's saying. Then later on, you gather about what she's telling you. Let her know you are listening through verbal and non-verbal clues or example. Nod your head or say, hmm. Maintain gentle and appropriate eye contact. Your attitude. Acknowledge how she is feeling. What you say. Give her the opportunity to say what she wants. Ask how can we help you? So always ask her that in what ways can we support her and in what ways we can help her. Encourage her to keep talking if she wishes. Would you like to tell me more? So just after some time when she has told you, and then you can ask her, would you like to tell me anything more? Then in don'ts, we don't have to do like, don't pressure her to tell her story. Don't look at your watch or speak too rapidly. Don't answer the telephone. Look at a computer or write. So at the time when she's telling you, you keep a eye contact and don't do other things. Don't judge what she has or has not done or how she is feeling. Don't say you should not feel that way or you should not feel lucky or you should feel that you are lucky you have survived. So you have to give her positive response and say that you are lucky that you have survived. Next slide. Allow for silence. Give her time to think. Stay focused on her experience and on offering support. Acknowledge what she wants and respect her wishes. Don't try to finish her thoughts for her. Don't tell her about someone else's story or talk about your own troubles. Don't think and act as if you must solve her problems for her. Next slide. Inquire about needs and concerns. How you act. So phrase your questions as invitations to speak. Ask open-ended questions instead of yes or no questions. Check your understanding by restating what she says. Reflect back to the client the feelings they express. Explore as needed. Ask for clarification if you don't understand. Help her to identify and express her needs and concerns. Sum up what she has expressed. Next slide. What would you like to talk about? What do you feel about that? You mentioned that you feel very frustrated. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or are concerned about? You seems to be saying that. So in this all way, you can inquire. Next slide, validate. Validate does not mean to try and verify the survivor story or explain, for example, through interviewing the alleged perpetrator, or witnesses. This is not safe, appropriate, ethical, or recommended. So show that you understand and believe them. It's not your fault. You are not to blame. You did the most important thing you could do in that moment. You survived. So you have to tell her. Help is available. Say this only if it is true. No one deserves to be hit by their partner. You are not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. I am worried that this may be affecting your health. It's okay to talk. Next slide. Empathy versus sympathy. Creating boundaries. So we have to understand the term what is sympathy and what is empathy. Sympathy is personal emotional identification with a survivor's experience and implies that the survivor service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over involvement and can take power away from the survivor. It is identifying with the survivor's experience through your own shoes. And the empathy implies intellectual personal understanding and realistic professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. It is the attempt to put oneself in the survivor's shoes. Ignoring violence can do more harm. So, providers' behavior can have possible consequences. So, blames or disrespect women or girls, it can lead to inflicts additional emotional distress or trauma. So, you have to make the person comfortable. Does not recognize gender-based violence behind chronic or recurring conditions. So woman receives inappropriate or inadequate medical care, fails to provide post-rape care or addresses gender-based violence in family planning, sexually transmitted infection, HIV care. So this can lead to unwanted pregnancies, STDs, that is sexually transmitted diseases, HIV, unsafe abortion, more violence. Breaches privacy or confidentiality. Partner or family member becomes violent after overhearing information. Ignores signs of fear or emotional distress. Woman is later injured, killed, or commits suicide. Next slide. The doctor helped me feel better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house the next time my husband became violent. So you may be his excuse, but you are never the reason for his violence. Women are not responsible for men's violence. Next slide. Mental health and support system linkages, helplines. So these are the different support: health, legal, justice, security, psychological support. Next. Warm referral practices help women reach further care. Registration and pre-test you have already done. After all the sessions, there will be a post-test and your valuable feedback. Certificate will be provided after attending all the topics. Thank you, ma'am. Thank you for sharing the slides.
Thank you, Dr.
Thank
Nandini.
you
So, for the
for
benefit
nice
of all
presentation.
who
Yeah.
have joined, I would just like to say that earlier the slides for violence against women was different, and now it is being modified as we give inputs. So the inputs are very valuable. Every time it can be modified according to the inputs. So we are asking for inputs. So next speaker, is she ready, Dr.
Yes, ma'am.
Prema?
Prema Priya. Yes, ma'am.
Yeah.
Shreema, sir, kindly make me co-host, sir, so that I can share the slides.
Is Shriman there?
Yes, ma'am.
Now
I'll
your
share the
host, madam.
slides. Okay, thank you. I'll share the slides. Is my slides visible, ma'am? Am I audible?
Yes, yes, you are audible and is visible.
Okay, thank you. So the next slide is about effects of violence against women on pregnancy and newborn. First of all, I'd like to thank Dr. Kiranmai, Dr. Vindhya, and Mr. Ajay sir for curating this PPT. So have you ever seen patients in your OPD who have been victims of violence or abuse? How do they present? How have you diagnosed? What are the common clinical presentations? Can you request a case scene? I think Dr. Nidhi has put a case scene of violence. Please others do put in the chat box.
Is Dr. Prema audible? I don't think so.
No, she's not audible, madam.
Yes, she's not audible.
Prema, are you there? Yeah, I think you have muted yourself. Unmute, Prema. Dr. Prema, you unmute yourself. Madam, am I audible?
Yes, you are audible. I am audible. Dr.
Okay.
Prema, who is talking, is not audible.
You unmute yourself, Prema.
And, yeah. Dr. Prema, you are not audible.
Madam left the meeting, madam. She'll join again.
She's going on. अर्पिता गांधी का मैसेज आया मैडम कि शी इज नॉट एबल टू ज्वाइन। बोले दो बार हम उसको क्वेश्चनर भरे, पता नहीं ज्वाइन कर। डायरेक्टली जूम से भी लिंक हो रहा है।
Ma'am, am I audible now, ma'am?
No. Yeah. Yes,
I just logged out and came back, ma'am. I'll share the slides, ma'am. Yes, ma'am. Now is it visible, ma'am? Am I audible? Shall I proceed?
Yes. Yes, you are visible. The slides are visible.
Yes, ma'am. So the woman interviewed in Peru has said, he hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. This suggests a high level of violence during the pregnancy. So let us see some case studies. So here's a prime gravida with premature rupture of membranes with prolonged and obstructed labor, presented with ruptured uterus and shock, and it leads to maternal mortality too. But later, the history revealed that history of brutal kicking on the abdomen by the husband and pushed violently, falling on a sharp edge, and the death was due to violence. Case study 2. There's a gravida 3 para 2 live to 28 weeks with previous 2 cesarean section, presented with antepartum hemorrhage, shock, and placenta accreta. Hysterectomy was done and 10 units of blood transfusion was done, and there was major bladder involvement. What preceded the bleeding was actually the husband kicking out the abdomen, which leads to abruption placenta, shock, and placenta accreta because of previous 2 cesarean sections. In a case study 3, a woman with severe preeclampsia, unconscious, with cerebrovascular accident leading to maternal mortality. Initially, the death was claimed as due to eclampsia. But actually what happened was the violence by the husband. The postmortem report reported that she had a fractured skull and cerebral hemorrhage, and the direct death was due to violence. So this was a case with the hidden violence masked as the mental disorders such as eclampsia. In this case study, she's again gravida 3 parieto live 2 previous to cesarean section full term. The rod was implanted where you can see due to fracture of femur or hip joint. She collapsed in front of the hotel and brought to the hospital in 108 in active labor with severe hypertension. An emergency dialysis was done with the consent of RMO as there was no attender with her. But when we asked the history, she told like she was pushed from the second floor 3 years back and now she was abandoned in labor. This is another case scenario where a third gravida para 2 live 0 with previous to LSS 36 weeks presented with severe anemia. Both times there was a history of physical violence, kicking on the abdomen brutally by the husband, followed by which she had loss of fetal movements and intrauterine demise. This was a third pregnancy where her parents brought her home, and due to severe anemia, the transfusion was given and LSS was done with a live baby. This is another scenario where 6th gravida para 2 live 2 with abortion 3 previous to cesarean sections. The 3 induced abortions was there, and this was an incomplete abortion with acute hemorrhage, shock, and sepsis. There is severe form of physical, emotional violence, forced abortions. The 3 abortions were forced abortions and abandonment. The domestic violence history brought out only by screening, and she received this time 4 blood transfusions. This was a picture showing the lacerations and stab injury by the husband, the lacerations on the face, and this was a perforation of uterus and intrauterine fetal demise. The laparotomy was done for her and the rent repair was done. Remember that obstetrics and gynecologist has a unique position. We as a specialist stakeholder in women's health need to assess and provide support for women who experience violence because of the nature of patient-physician relationship. There are many opportunities for us to intervention that occur during the course of, it can be during the adolescence, during pregnancy, family planning, annual examinations, or any other women's health visits. How to elicit the history? Mainly by the indirect questions. We can ask like, is everything all right at home? Are you getting on with your partner? There are certain screening tools such as abuse assessment screen, HARK screen, that is humiliation affright, rape kit screen, woman abuse screen tool, etc., where we could use the screen tools and assess for violence. According to WHO 2018, it recommends that all health professionals be trained in first-line response to family violence. The steps are to listen, believe, inquire about needs, validate the person's experience, enhance safety, and offer the ongoing support. Does universal screening is required? Universal screening or routine screening about intimate partner violence is not recommended. However, WHO guidelines tells that to identify antenatal care setting as a setting where routine inquiry could be implemented if providers are well trained on a first-line response and as minimum requirements are met. The evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain. A minimum condition for healthcare providers to ask women about violence is that it must be safe to do so. That is, the partner should not be present while asking the question because she may be afraid she may not come out. Or if she comes out, then when going home, they can have problems. So make sure that it is safe to ask the question. An identification of intimate partner violence is followed by an appropriate response. Detailed guidance on responding to intimate partner violence and sexual violence against women could be found in WHO 2013 clinical and policy guidelines. Please remember to write the post-test and feedback form so that the certificates will be avoided. And I would like to share the next PPT. And most of the women in many parts of the world speak the same language, that is silence. And it's up to us obstetrician gynecologists to be the voice of the silence victim. Shall we move to the next
Yes, yes,
discussion, ma'am? Mental health issues.
yes.
Coming to the mental health issues in women who suffered violence. Here is a case report. Mrs. R, 26-year-old woman, was brought to the hospital with complaints of sudden abdominal pain. She was 28 weeks pregnant and married for 1 year, and this was her first pregnancy. She was a booked patient on regular antenatal checkup, and she's non-diabetic or hypertension. On examination, she was very depressed. Her vitals were stable. Uterus was 28 weeks, irritable, and fetal heart rate was normal. Vaginal examination was unremarkable. On inquiry, she came out with a history of being beaten by her husband. So what are the details to be gathered from the patient? Whether we need to inform the police, how to counsel the patient, what are the problems the patient can come across, what about family planning, family counseling, any drugs can be suggested, what about the aftermath of intimate partner violence? Please put your comments in the chat box. As already Dr. Niti has started her comments. Others, please try to put your comments. So it will be definitely valuable for us. So there should be need for triad of consultations with the obstetricians, psychologists, and psychiatrists. Why mental support is needed? Because post-traumatic stress disorder is considered a life threat or injury. Hypervigilance is needed to detect mood disorders such as depression, suicide, substance abuse, sexual disorder, phobias, functional GI symptoms, dissociation symptoms, and social withdrawal. First-line support is mainly by the Obgyn providers. So we, the role as obstetricians, has a role of intervention to do risk assessment, such as what is the frequency of violence, how it is severe, whether it is chronic or not. We should assess the safety risk from further assault from the partner, psychological screening, suicide and danger assessment risk. Assess the domestic homicide risk also. These are some of the danger signs. The frequency of violence is more, presence of severity of injuries, alcohol misuse, threatened to kill by the partner, sexual violence, suicidal ideation in the woman, access to weapon by the partner, and morbid jealousy in the partner. So when to hospitalize her? In case of severe medical injuries, suicidal or homicidality thoughts, dissociative symptoms, mood instability, self-destructive behaviors, or serious threat to patient's life. So we can admit the patients and we can approach the Gender-Based Violence Agency or One-Stop Crisis Center for help. Remember, it should be individualized and multidisciplinary treatment is needed. The primary treatment modalities include safety assessment, suicide and danger assessment risk, milieu therapy, that is change in the environment of the patient, mood stabilization, medication evaluation, psychosocial support, need for rape kit, photo documentation, and reporting legal concerns. This is one of the trauma recovery clinic, which started in 2014 at Niemann's. The main objective of this is to enable the survivors to come out of the trauma, to reclaim their lives by reducing the emotional symptoms of trauma, enhance their self-esteem and resilience, improve the social support, prevent re-traumatization, and conduct awareness and capacity building programs for psychologists and counselors. And this is mainly the need of the heart today. Coming to the psychosocial impact of the violence, the victim may feel helplessness, and there could be a progressive erosion of their confidence and self-esteem because of the abuse. They could feel guilt, shame, isolate, traumatic bonding, paradoxically strengthening the emotional ties to the perpetrators, physical separation, which could lead to increased risk of homicide, and decreased coping abilities in the victims. So what about the role of psychologists? They play a main role, especially in the case of post-assault. Psychotherapy is needed. Cognitive behavior therapy, exposure therapy is needed. The variant of cognitive therapy is it helps the victims to emotionally process the assault by decreasing the fear to memories or cues of the event. There could be a brief trauma-focused cognitive behavior therapy. This is a STAR, that is skills training in affective and interpersonal regulation. This includes psychoeducation about the impact of trauma on emotions and relationships, emotional regulation skills, effective expression of negative emotions, interpersonal skills related to appropriate assertiveness, and development of flexibility in regard to interpersonal expectations, actions, and reactions. Treatment also includes recognition of achievements during the treatment and exercise in impact of self-compassion. Coming to the interpersonal psychotherapy, it has been shown to be an effective non-exposure-based treatment for post-traumatic stress disorder. and reflect the interpersonal difficulties such as emotional withdrawal from relationships or individuals. Interpersonal deficits, sometimes loneliness, results in interpersonal hypervigilance. So other newer psychotherapies includes cognitive processing therapy, eye movement desensitization reprocessing, relapse prevention, relationship safety. Women experiencing intimate partner violence related depressive disorder or alcohol disorder should receive mental health care as per WHO Mental Health Care Action Program Intervention Guide 2010, delivered by health professionals with good understanding of violence against women. Cognitive behavior therapy and eye movement desensitization reprocessing interventions delivered by the healthcare professionals with good understanding of war are recommended for women who are no longer experiencing violence but suffering from post-traumatic stress disorder. And these are some of the WHO recommendations for depression and emotionally or medically unexplained conditions. In case of mild and initial phase, no need of any antidepressants or benzodiazepines. Whereas in case of moderate to severe depression, tricyclic antidepressants or fluoxetine can be started. And it should be continued for 9 to 12 months, even after recovery. Interpersonal therapy and cognitive behavior therapy, including the behavioral activation and problem-solving treatment, should be started. There could be a relaxation training and physical activity. The psychological support after the recent traumatic event mainly consists of psychological debriefing and psychological first aid for acute distress. The men should be involved, encouraging men to take personal responsibilities for violent behavior, challenging their attitudes around the use of violence in relationship, developing skills for reacting non-violently to others, and increasing the awareness of dynamics involved in use of violence. This could be helpful to prevent the domestic violence. So, mental health is an issue in violence against women, affected women, and thus it needs to be addressed along with physical health. Kindly fill your post-test and feedback form so that you'll be receiving your certificates. Thank you. Thank you for your patience listening.
Thank you so much. Your presentation was very nice, Dr. Prema Priya.
Thank you.
Now next, next topic is challenging situation in violence against women. And I think Rekha madam, start sharing slide. I have to speak. Challenging situation.
Challenging issues and self-care in dealing.
So thank you, and my heartfelt thanks to Dr. Kiranmai Devinani and along with Mr. Ajay Bhardwaj who have prepared such program. And I have to speak challenging situation in violence against women and how to take care of themselves. So next slide. When dealing with a survivor who may be feeling hopelessness, having suicidal thoughts, or may harm herself, we have to take care of her by emotional support, by psychological support, as well as by providing her physical support. So these are the challenging issues which we have to see and we have to cover. We have to behave with her as her friend so that she can converse every complaint, everything what she has felt, so that we can solve her problem. Next slide, madam. So what we have to do, being a gynecologist, and one of your patient in your clinic tells that she is being threatened by her mother-in-law, who is constantly pressurizing that she must divorce her husband because she is unable to have children. She feels hopeless and wants to give up. So what we should do, please write the answers what you feel as a gynecologist, because we see in our practice such patients come to us and they complain. So what we have to behave and what we have to say her. So please write down what you feel, and we will later on discuss, so that these inputs are necessary in making the module, so that we can add these inputs also in next module. Next. So these are a few ideas. Be able to recognize signs of depression, suicide risk. Whether patient is very depressive and she may commit suicide. So what we have seen to patient, we will discuss with her that these are the complaints and these are the things which she is facing, and we have to cover. Don't be afraid to ask, are you having thoughts of suicide? That we should ask her. If we are seeing that she's very nervous, she's very depressed, and she always comes with the same complaint that my mother-in-law is abusing me, and other family members are also abusing, and they are saying that you give divorce and you leave the house, then we have to ask her whether she is feeling so depressed that she can commit suicide. So if the answer is yes, take it seriously, because many times a woman can do suicidal attempt. So don't leave the suicidal survivor alone if there is immediate danger. Always consult a supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. So if the patient is so depressed that she can commit this type of attempt, we have to take it seriously, and we have to go for psychological analyst or supervisor, so that they can convince her that this is not right way to commit suicide or to end her life. So provide a referral to a gender-based violence expert agency or for additional help if possible. So if there is a risk of suicide or any serious disorder of depression, then we have to consult the psychoanalyst, or we have to go for a gender-based violence expert, so that they can convince her and she will leave this type of thoughts in her mind. Next. So we, as Obgyn gynecologists, should not ask survivors about suicidal thoughts attempts. It could encourage suicidal attempts. So this is the question. So if true or false, I think it should be true. We should ask. We should not say that is false. We should ask, because many times she or a patient tells us that she is so depressed that she can do. So I think if it's very depressed, we can ask her. So what is your opinion? You can write the answer in the chat box. Next. Asking about suicidal attempts or thoughts does not increase. Previous one, madam.
Previous one.
Yes. Asking, this is false. Asking about suicidal attempts or thought does not increase suicidal attempts. On the contrary, talking about suicide often reduces the woman's anxiety about suicidal thoughts and helps her feel understood. Because if she narrates her story and she feels better, then I think we should ask her and we should convince her that she should not take such type of steps for to end her life. Next. If the survivor tells you that their abuser had threatened to harm them, what should you do? So, as a gynecologist, please answer in the chat box what we should do if the survivor tells us about her story, and ask concrete questions about safety risk, but only when there is a privacy. So we have to ask her separately in privacy, so that her partner or her other family members are not present, because she may not be able to say frankly. So we have to maintain privacy, and then only she will narrate her story. Ask if survivor has a safety plan in place in case she needs to flee. We have to ask her whether she has any safety plan, because sometimes she remains alone in her home. Her in-laws or other members, even her husband, may beat her, may try to kill her. So we have to ask about her. Discuss potential strategies for being able to leave her situation safely. So what can be strategies? How can she escape from this situation? We have to discuss, and provide a referral to a gender-based violence expert agency, that is one-stop crisis center, for additional help if possible. If there is serious concern, then we can make her referral, so that she can go there and she can narrate her story and she can find the solution. Next. One of the most helpful techniques for helping a survivor to get out of an overly emotional state, to ask them close-ended questions that require them to think. So shift them from an emotional state to a cognitive state. Because the patient is so depressive, she always remains very emotional. And when we ask, she may start crying and will tell everything. So we have to console her. We have to make her that what she should think and what she should do. We should require short answers. Don't return to open-ended questions unless the survivor feels comfortable, has some degree of emotional control. So we have to take care of her emotions. If she wants to cry, if she wants to take some time, we can give her, so that she will feel comfortable, and then she can tell about her story, and we can help her. What are some examples of close-ended questions that you might go to in situation like this? Ideas in the chat. So, like how many kids do you have? Are they in school right now? What ages are they? We have to divert her so that she can get away from that emotional state and she can think about the situation. So we have to divert by asking some other questions. Next. So what are the challenging issues when dealing with a survivor who may be mentally ill? State clearly who you are and your role. We have to behave with her as not only as a doctor, but as a friend, as a counselor. Be empathetic. We have not to be sympathetic, but we have to be empathetic, non-threatening, and sincere in your intention to help. Give honest, factual answers whenever necessary. And if you don't know, say so. Do not belittle concerns which the survivor raises. Do not give advice as to handling of their psychological problems. Attempt to be supportive in comments and gestures. Don't assume mentally ill people should know better, or on the other hand, that they need to be told what to do. Be careful about making any assumptions. Know how to activate emergency mental health backup. So we have to make her strong, mentally, emotionally strong, so that she can tackle the situation, and we have to make her to go to that clinic or a gender-based violence expert so that she can find the solution of her problem. Next. So these are the additional challenges issues like meditation. What do you think? Can be part of meditation process? Remember, meditation is not recommended as a response to gender-based violence. Remember, health workers are part of a survivor-centered referral mechanism. The meditation process self-maintains and contributes to abuser's ongoing power and control over a survivor. The process of mediation presumes that both parties can speak freely, confidently, and safely. That is not the case. Mediation rarely results in an end to the abuser's violence and can actually lead to an increase in the violence. It is unlikely the survivor's rights will be respected. So I think this is mediation, not meditation. I've read wrongly.
No.
Mediation.
No, it means mediation, like
Yeah, mediation. Yeah,
samjhota
media.
karana. Samjhota
Pata,
karana
media.
is not good.
Yeah. So I think actually this has been changed, madam. Earlier, what training we have
Yes,
taken,
this is
these
the
are
new
different from that.
module for the
Yeah.
elder people about
Yeah.
the domestic violence and about
Yeah.
sexual gender-based violence. So
So
earlier we were speaking about adolescents. Now we are
yeah.
speaking about more elder people,
Yeah.
and this is mediation. That means
Media.
interfering or patching up between couples. That rarely results in any end to the violence. It can build up the toxic environment and the toxic
Yeah, it
cycle
may
more and
aggravate
more.
it. Yeah, it
Yeah.
may aggravate. So mediation is not recommended as a response to gender-based violence. Next, madam. Yeah. Core safety precautions when dealing with the challenging issues or cases. Multiple people can handle difficulty better and more efficiently than one person. A service provider should never feel like he or she must work alone with the survivor. A service provider should not work with both the perpetrator and the survivor, neither separately nor in the same interview. That is, we have to, I think, interview them separately. Keep the office door open of leaving the office or home if feeling unsafe. Establishing a code word with co-workers to identify unsafe situations. Establish a relationship with the local police or security. Use buddy system at work and to and from work if doing home visits. Use supervision to address security concerns. That is, a group of people can address security more effectively than an individual. So I think if one body cannot handle properly, then we can involve some people who can address securely more effectively, especially those who are concerned with these things. Then we can take help of them and we can help her the situation to come out of the situation. Next. So self-care for the provider, it is critical for you. Do you know what is vicarious trauma? Put your comments in the chat box. So please, if you know what is vicarious trauma, please write down the answer. Put your comments in the chat box, yes or no. As a service provider, you should be aware of it for self-care. So we have to take care and how make her strong that we have to learn so that we can convince the patient to take care of herself at home or wherever she feels wellness. Next slide, madam. So vicarious trauma, a change in a service provider's inner experience is a result of emotional engagement with survivors of trauma and hearing their stories. So this is vicarious trauma. Changes that occur in the service provider's physical, emotional, and or behavioral states as a result of constant exposure to traumatic stories or events. So these are called vicarious trauma.
No, vicarious trauma means the trauma that you start experiencing after listening to somebody, then your views are changing. That is vicarious. Being influenced by some trauma.
Yes. So if somebody is having some injury or some type of trauma, and if we hear her story, then we can feel traumatic. So that is, I think, vicarious trauma, right?
Yes.
Constant exposure to stories of trauma, if that is vicarious trauma. If we hear stories of trauma regularly, frequently, then we can have such type of trauma. Desire to help or change survivor situation. Feeling powerless when a service provider does not see positive changes in a survivor situation. If we don't find any positive change when a survivor comes to us, then we feel trauma, that is vicarious trauma. And overly identifying with the survivors, thinking that a service provider has the power to change a survivor situation, that we think that we can change, but we are not able to change, and that we feel traumatic. That is, I think, this is vicarious trauma. Next slide. So preventing and managing vicarious trauma, ABC, awareness, being attuned to one's needs, limits, emotions, and resources. Practice self-acceptance, balance, maintaining balance among activities, especially work, play, and rest. So I think these all are necessary. If we hear such type of stories frequently, then we have to balance ourselves. Connection, maintaining supportive relationship, communication is part of connection and breaks the silence of unacknowledged pain. These connections help prevent isolation and increase validation and hope. Self-care for the health provider, creating boundaries in the workplace, establishing support within the work environment, seeking assistance from outside agencies, creating our own self-care plans and following them through. So if we feel such type of vicarious trauma, we have to take care of, I think, ourselves, because this is for health provider. Next. So empathy versus sympathy. This is pick which statement describes sympathy and which statement describes empathy. Statement 1. A personal emotional identification with a survivor's experience and imply that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. So I think this is sympathy.
Yes.
Statement 2. An intellectual or personal understanding and realistic or professional distance. It involves compassion and objectivity and leaves room for the empowerment of the survivor. So this is empathy. So I think we have to be empathetic, not sympathetic, because it will empower the survivor. Next. So put your comments in the chat box that has been given. So how do you take care of yourself? Put in the chat box. Some relaxation and self-care techniques are necessary, and that we have to adopt in our lives, because if we are strong, if we are taking care of ourselves, then only we can help them. So next. So registration and pre-post test is necessary, then only certificates will be awarded. So after the whole course, there will be posted, please appear for that test, then only certificates will be given. Thank you so much.
So it was a very nice session by Kavita, and she was speaking on the support systems for the survivors. The next topic is, let me see what it is. The next is the support systems, rehabilitation, and resources for the survivors. This is it, na, Kavita? support systems and resources for the survivors. Overview of the section. Now we should know what are the protective laws and acts, what are the helplines, what are OCCC, one-stop crisis centers, and how can we link up and help in rehabilitation of the survivors. The Protection of Women from Domestic Violence Act 2005. Why Domestic Violence Act 2005? 498A into the Indian Penal Code was introduced in 1983. No emergency relief available to the victim. Remedies available were linked to matrimonial proceedings, and the court proceedings were always protracted, during which period the victim was invariably at the mercy of the abuser. Relationships outside the marriage were not recognized. So, why Domestic Violence Act 2005? 2005 Act is a civil law. In 498, a husband is liable for punishment, but wife does not get any financial relief. But in domestic violence, wife or the female partner gets relief, but there is no punishment or arrest unless the husband violates the court order. Another difference is 498A can be booked under husband or his relatives, but domestic violence can be booked only against male members of a family. Who can be a complainant? A wife or a woman based on consanguinity, marriage, adoption, and cohabitation against a male abuser in a shared household. A woman who is in a relationship similar to a marriage with a man, technically a transgender male to female could bring an action against a transgender female to male. A woman in a live-in relationship with an unmarried man, but not with a man who is married if she knew or ought to have known that he was married. Anyone can file a petition with the survivor's consent. So in the Domestic Violence Act, things were incorporated that not only a partner who is in a valid marriage can complain, but others who are in such a relationship can also bring up a complaint. So to whom can we complain, or you can complain? Protection officer, service providing center, medical officer in charge, police station, or a magistrate. Now, where can you complain? Jurisdiction under PWDV Act, where the wife uh, that is permanently or temporarily resides or carries on business or is employed, or where a husband permanently or temporarily resides or carries on business or employed, or where cause of action has arisen, the wife can choose any of the three options. So, in the previous slide, it was said to whom you can complain. Protection officer, service providing center, medical officer in charge, police station, or magistrate. And in the next slide is where you can complain. Types of orders that can be given. The types are protection orders to stop violence, emergency relief, residence in a shared household irrespective of whether she has any right of ownership or lease. In this, the example can be given that if the house belongs to the male partner, still she is allowed to stay there even if she is not the owner of that property. Can require separate housing, and abuser must provide for separate housing. Custody order, compensation order, violation of the above order, an offense, and magistrate may charge the offense. So these are the types of orders can be issued after the complaint has been lodged. So she can be given protection, the violence can be stopped, emergency relief measures can be taken, she should be allowed to live in that same household or some other household for which the money has to be provided by the abuser. custody can be given to the parents, for example. Compensation can be asked from the perpetrator of the crime. Violation of the above order an offence, and a magistrate may charge an offence. Magistrate has the power to do that. So, Section 31, non-compliance of a protection order by magistrate can lead to issuance of a non-bailable warrant. So, the person, the perpetrator, has to follow the order passed by the magistrate. Otherwise, he will get a non-bailable warrant. Time prescribed by the Domestic Violence Act. The Act requires that all the proceedings brought under the Act be disposed of within 60 days of the first hearing, which must occur within 3 days following the application. So what does it imply? The Act implies that within 60 days of the first hearing, the whole thing should be settled. And the hearing should be made within 3 days. The complaint should be made within 3 days. So the services offered are file a detailed investigation report, direct complainant to a shelter, facilitate free legal services, provide the counseling services as and when required. Domestic legal remedies in India. The Constitution of India, Article 14 on equality, the National Commission for Women set up as statutory body in January 1992 under the National Commission for Women Act 1990, the Dowry Prohibition Act 498A IPC. This is most widely used used provision against domestic violence, and the Protection of Women from Domestic Violence Act in 2005. The concept of one-stop crisis centers. The one-stop crisis center caters to the immediate medical, legal, and psychological needs of the women who are survivors of physical and mental abuse, with an assurance that the consent and confidentiality will be respected and protected. This is a joint initiative of the Department of Public Health and Family Welfare, Government of Madhya Pradesh, and Action Aid, supported by Police Department. Gauravi's staff of 10 focuses on the victim's needs without compartmentalizing the services. This is since June 2014. And there are other centers known as the Sakhi centers all over India. Bharosa Trust, Bharosa Center and She Teams Office, an all-in-one for violence against women with police, counselors, psychologists, legal advisor and medical help. The helpline is 100 and will be directed to Bharosa if it is violence. Take screenshots of the next 3 slides. A woman can walk in with the assurance that her consent and confidentiality should be maintained and protected. So these are the helpline numbers you should contact. All India Women's Helpline, Women in Distress. These contact numbers you should give to the woman. You should paste it in front of your office so that if a woman requires, if she wants to know, she will get to know the helplines numbers. So All India Women Helpline, Women in Distress is 1091. Women's Domestic Abuse Helpline is 181. National Commission for Women is 01126942369 and 01126944754. So there are other helpline numbers, and I think you must have taken the screenshots by now. Now the Bhumika Women Collective that is in Andhra Pradesh, in Arunachal Pradesh, there are numbers in Andaman Nicobar, there are numbers in Bihar. So we are doing in Bihar, so you have Sahyogi and Oxfam, Mahila Jagran Kendra. There are 3 numbers on the screen which you can take a screenshot of. Sahyogi, that is 98350 83482, and Oxfam 114653 8000, and Mahila Jagran Kendra 0612 220 7912. And other helpline numbers of other states are there. So there are many by many names in all the states. And this is again a slide for the helpline numbers of these centers which you can take. And again, reminding each time about the pre-test and the post-test. Please continue for the post-test. Wait for some time after the end of the session. You will get a post-attendee Zoom, and then you can go through the post-test. So thank you very much for your patient listening. And if Dr.
Madam, thank you
Sunita
so much.
Singhal is there,
Dr. Nandini will take this session, madam.
okay. So
Dr.
Dr.
Sunita
Sunita
has,
is not
yeah.
there.
No, she
Okay.
has requested
Then
her to
again,
take.
for Dr. Nandini, I think again I have to share the slide,
Yeah.
isn't it?
Yeah.
Hmm. So, shall I
I
start?
think this is
You are
this is yeah.
not.
This is last session, no? This is last
So
session.
you unmute yourself, Dr. Nandini, please. Unmute yourself, and I will
Please,
Thank
share
you,
the
madam,
slide.
for sharing the slides.
Yeah. So if I had known, then I could have spoken on all the slides. If I had to
then
share
better
all
than
the
you
slides.
continue.
No, no,
Madam,
ऐसे कर रहे हैं. She can do it. So, sexual violence. How to approach a woman facing sexual violence. This is it. How to? Can you start, Dr. Nandini, or should I
Yes,
start?
yes, ma'am. Yes,
So you
sexual
start.
violence, how to approach a woman facing sexual violence. Next slide. So sexual violence refers to any sexual act or attempt to obtain a sexual act or unwanted sexual comments or acts to traffic that are directed against a person's sexuality using coercion by anyone, regardless of their relationship to the victim in any setting, including at home and at work. Next slide. Rape is a term that is commonly used for the first type of sexual violence mentioned, forced coerced intercourse. WHO definition of sexual violence includes but is not limited to rape, which is defined as physically forced or otherwise caused penetration of the vulva or anus using a penis, other body parts, or an object. Chances are you know someone who has been sexually assaulted. Victims usually know their assaulter. Victims are never at fault for their sexual act, sexual assault. Rape is the least reported and convicted violent crime in the world. Sexual violence is preventable. Help is available. So forms and context of sexual violence. A wide range of sexual violent acts can take place in different circumstances and settings. Rape within marriage or dating relationships, rape by strangers, systematic rape during armed conflict, unwanted sexual advances or sexual harassment, including demanding sex in return for favors, sexual abuse of mentally or physically disabled people, sexual abuse of children. Next slide. Forced marriage or cohabitation, including the marriage of children, denial of the right to use contraceptive or to adopt another measures to protect against sexually transmitted diseases, forced abortion, violent acts against the sexual integrity of women, including female genital mutilations and obligatory inspections for virginity. Forced prostitution and trafficking of people for the purpose of sexual exploitation. Next slide. Customary forms of sexual violence, child marriage. Marriage is often used to legitimize a range of forms of sexual violence against women. Marrying of young children, particularly girls, many parts of the world. This takes place even now. Legal in many countries in a form of sexual violence, children involved unable to give or withhold their consent. Majority of them know little or nothing about sex before they are married. Next slide. The consequences of sexual violence. Pregnancy and gynecological complications, sexually transmitted diseases, mental health issues, suicidal behavior, social ostracization. Next slide. Fatal outcomes related to sexual violence, suicide, homicide, AIDS related. Non-fatal outcomes related to sexual violence, physical consequences, unwanted pregnancy, infertility, sexual dysfunction, chronic pelvic pain, sexually transmitted infection, including HIV infection and AIDS, obesity or anorexia, urinary tract infections, gastrointestinal disorders, gynecological and pregnancy complications, migraine and other frequent headaches, fatigue, nausea. Non-fatal outcomes related to sexual violence, psychological consequences, rape trauma syndrome, post-traumatic stress disorder, social phobias, shock, increased substance use or abuse, denial, fear, confusion, anxiety, guilt, depression, alienation, and eating disorders. Next, approach to survivors of sexual assault. Sexual assault is one of the most invasive and intimate forms of violence. A trauma-informed care (TIC) approach should be utilized. Involves thorough understanding of neurological, biological, psychological, and social effects of trauma and violence on the individual. When a patient presents and reports a sexual assault, triage the patient as a medical emergency. Next slide. Immediate needs of a survivor of sexual assault. Medical and or psychiatric evaluation and stabilization. Activation of community advocacy to the bedside. Mandate reporting as directed by statuses, offering and conducting, if desired by the survivor, the sexual assault forensic examination, that is SAFE. Collaboration with law enforcement, if desired by the survivor. Prophylactic medications for sexually transmitted infection and sexually transmitted diseases. Pregnancy risk evaluation and care and safe discharge planning. Those providing medical and forensic care must always be prepared to provide testimony as either a fact and or expert witness. Next slide. Application of trauma-informed care to the care of the patient discloses assault to the patient that discloses sexual assault. So safety, trustworthiness, choice, collaboration, and empowerment. Safety. Knock on the door and ask permission to enter the patient's room. Meet with the patient before they disrobe. Ask the patient to disrobe only when necessary or only partially disrobe. Provide and clearly identify washrooms. Take time to familiarize the person with the physical environment. Ask about comfort level with lightning. Share control, show respect. Use a warm and compassionate manner to build rapport. Trustworthiness. Explain all procedures in terms the person can understand. Tell the person what to expect and how long it will take. Ask the person what he or she wants. Choice. Ask if you can touch them each time. Ask before you invite in additional staff. Ask if you can close the door. Allow the person to decide whether to sit in the room. Explain rationally for each procedure what the procedure will feel like and make appropriate modifications to reduce re-traumatization. Obtain consent for each part of the exam performed. Collaboration. Ask what are your top worries or concerns and address these first if possible. Share information. Encourage the person to make decisions about treatment. Next, empowerment. Ask what happened to you, not what is wrong with you. Never ask why questions as they imply fault. Take time with the person so he or she feels genuinely heard. Ask if the person has preferences related to or has had difficulty with a particular procedure. Ask the person what you should know before you begin the procedure. Ask if there is a way you can make the procedure easier for him or her. Ask if there is a way you can make the person relax, like a different position. Pay attention to body clues. Many survivors have been conditioned to be passive and defer to authority, and so may not disclose distress during a procedure. Elements of the SA history. Medical elements of the sexually assault history. Medical history, recent consensual sexual activity, assault related medical history, sexual assault details, nature of the physical assault, post assault activities, suspect information. After all the procedures of all the topics, kindly give your valuable feedback, and after that the certificate will be provided to you. Thank you very much.
So now coming over to the last part of the module, the last module. This is examination of a survivor and collection of the evidence. So this is very important on our part, how to examine a survivor and how to collect the evidence. The role of the gynecologist here is to use important evidence of the crime, help judges understand the physical and mental condition of the survivor, use reports to corroborate the survivor's story and enhance the credibility, offer primary level counseling treatment and referral for the physical and psychological sequelae. Medical examination. First, record the history. Do the informed consent. Do the injury documentation. Evidence collection in the nature of sexual violence, time elapsed between the incident and the examination, whether the survivor has bathed or washed her private parts. Remember 25 things to do. General instructions, informed consent, marks of identification, relevant medical and surgical history, history of sexual violence, type of physical violence, emotional abuse, etc., general physical examination, examination for injuries, the external genitalia, systemic examination, evidence and sample collection, provisional medical opinion, treatment prescribed, date and time of completion of examination, and the final opinion. So these are the things to be done. You can take a screenshot if you want, or we can for it may be helpful for the post test if you want to read it again. And then medico legal examination, report of sexual violence. This is the format: name of the hospital, OPD number, inpatient number, name, whether wife of, son of, or daughter of, address, age, sex, date and time of arrival in the hospital, date and time of commencement of the examination brought by the person, uh, and medical license number, police station, whether conscious, coherent, oriented in time and place and person, any physical, intellectual, or psychological disability. Interpreters or special educators will be needed where the survivor has special needs such as hearing or speech disability. Informed consent / refusal. I hereby give my consent for medical examination. It should be clear yes or no. Medico-legal examination, yes or no. Sample collection for clinical and forensic examination, yes or no. I also understand that as per law, the hospital is required to inform the police, and this has been explained to me. I want the information to be revealed to the police. I have understood the purpose and procedure of the examination, including the risk and benefit explained to me by the examining doctor, my right to refuse the examination at any stage, and the consequence of such refusal, including that my medical treatment will not be affected by my refusal, has also been explained and may be recorded. So, and in any case, you have to give the medical treatment even if she refuses the examination. Contents of the above have been explained to me, language with the help of a special educator, interpreter, or support person. If special educator, interpreter, or support person has helped, then his or her name should be also mentioned there and her signature should be taken. Marks of identification: any scar or mole and the left thumb impression. Relevant medical and surgical history: the onset of menarche in the case of girls, age of onset, menstrual history, last menstrual period, menstruation at the time of incident, menstruation at the time of examination, was the survivor pregnant at the time of incident? If yes, the duration of pregnancy, contraceptive use, yes or no? If yes, what was the method used? Vaccination status, tetanus, hepatitis B, whether vaccinated or not. Date of incident being reported, time of incident, the location, estimated duration 1 to 7 days, 1 week to 2 months, 2 to 6 months, or 6 months. Episode 1, multiple, chronic, greater than 6 months, unknown, number of assailants, name, sex of the assailants, approximate age, if known, relationship to the survivor, description of the incident in words of the narrator, narrator of the incident, survivor, informant, name and relationship to the survivor. Add an extra page if necessary. So it should be recorded in very detail. All the perpetrators of the crime should be described and they should be noted down, the number of assailants and everything, and how many times this situation has occurred. So hit with hand, fist, or a blunt object or a sharp object, burnt with kicking, pulling hair, banging head or dragging, biting, pinching, violent shaking, any other. Emotional abuse or violence, if any, insulting, cursing, violating, terrorizing, use of restraints, if any, use or threatened use of weapons or objects, if any. Whether the weapon has been used or threatening about using weapons has been made. Verbal threats, for example, threats of killing, or hurting the survivor or any other person survivor is interested in, use of photographs for blackmailing, if any, luring, sweets, chocolates, drinks, alcohol, drugs, money, job, if any. So luring by offering a drink and then sedating her, or offering a job and then doing some sexual offense, all this should be recorded. Any other. Any history of alcohol or drug intoxication, whether sleeping or unconscious at the time of incident. If the survivor has left any marks of injuries on the assailants, details of those injuries. Details regarding the sexual violence, the organ, by penis, by body part of self or assailant or third party, finger, tongue or any other, by any object, emission of semen, whether it is known or not known, genitalia, vagina and urethra, anus and mouth. So all these body parts should be separately mentioned and recorded what has been done. Details regarding sexual violence, oral sex by the assailant, forced masturbation of self by survivor, forced masturbation of assailant by survivor, forced manipulation of genitals, exhibitionism, perpetrator displaying the genitals, did ejaculation occur outside the body orifice, vagina, anus, mouth, urethra? If yes, where on the body? Condom used? If yes, status of condom. Lubricant used? If yes, describe the kind of lubricant. If object is used, describe the object. These all will be used as a corroborative evidence. That is why details of the lubricant and everything should be there, so that the corroborative evidence can be taken and the perpetrator has to be pinned down. Post-incident details. Post-incident, has the survivor changed clothes, undergarments, washed the clothes, washed the undergarments, bathed, doused, passed urine, passed stool, rinsing of mouth, brushing, vomiting, anything has been done, should be noted as yes, no or do not know. Time since the incident and any other remarks. History of vaginal, anal, oral bleeding, discharge prior to the incident of sexual violence. History of vaginal, anal, oral bleeding, discharge since the incidents of sexual violence, or painful urination, painful defecation, fissures, abdominal pain, pain in genitals, or any other part since the incident of sexual violence. General physical examination, height, weight, general build, gait, pulse rate, blood pressure, temperature, respiratory rate, pupils, any other disability or deformity. This is required for the treatment also, and for further any surgery or anything is required or not. So full general examination is done, should be done. Examination for injuries on the body. What are the injuries that can be seen and recorded? Bruises, nail abrasion, teeth bites, cuts, lacerations, fracture, tenderness, boils and burns. Where to look for? On the scalp, face, neck, shoulders, breast, wrists, forearm, medial aspect of the upper arms, thighs and buttocks, and what are the size, shape or color of the bruises, swelling, signs of any healing, simple or grievous wounds, and the dimensions of the wounds. External genitalia, record findings, labia majora, minora, urethral meatus, vestibule, fourchette and introitus, perineum and hymen. Per speculum findings if performed, per vaginal findings if performed. Record the reasons for the per speculum and per vaginal finding. Examination, anus and rectum, bleeding, tear and discharge, edema, tenderness, oral cavity, bleeding, discharge, tear, edema and tenderness. So it should be very detailed about all the areas mentioned. Now the systemic examination, CNS and CVS, respiratory system and abdomen, because with the sexual abuse, the physical abuse is going on. So any injury to the CNS or CVS or respiratory system or abdomen anywhere, that has to be seen and recorded. Now going on to the next slide, evidence collection, sample collection, to obtain confirmation of the allegation, to establish link between the victim and the scene, to establish the link between the victim and the assailant. So these are the things which is the medico-legal things, which for the forensics, these things are needed. Now, next slide. Always maintain the chain of evidence, identify the specimen, label the specimen, and sign the label, record the disposal of the specimen. Sample collection and investigation. Hospital or lab, clinical lab, blood for HIV, VDRL, HBsAg, HCV, urine test for pregnancy, ultrasound for pregnancy, internal injury, X-ray for injury. Central State Forensic Lab, debris collection on the paper, clothing evidence were available to be packed in a separate paper bag after air drying. So, any sample of any debris or clothing of the victim should be sent to the forensic lab. Swabs from stains on the body, any blood, serum or foreign material, scalp hair, 10 to 15 strands, head hair combing, nail scrapings, both hands separately, oral swab, blood for grouping testing for drugs and alcohol, blood for DNA analysis, urine, drug testing, any other tampon, sanitary napkin or condom, any object. So, genital and anal evidence. Matted pubic hair combing, cutting of the pubic hair, 2 vulval swabs, 2 vaginal swabs, 2 anal swabs, and vaginal smear. For semen examination, urethral swab, sample to be preserved as directed till handed over to the police along with the duty attested sample. So we need samples of everything, pubic hair, vaginal vulval swab, all for the semen and for any DNA which the perpetrator of the crime must have left on the victim. So it is very necessary. We know the victim's DNA, but we can detect the DNA of the perpetrator from these swab or from the evidence which we are collecting. So it is very important to collect everything, the vaginal and urethral swab and also the specimen of the pubic hair. Now coming to the provisional medical opinion, I have examined such and such a person aged reporting. She has been reporting sexual violence under such and such circumstances, the number of hours and days after the incident, after having bathed, doused or number of times. So everything should be very clear and very explicit in this format. What is the age, when the crime occurred, what happened after the crime, and when she has come to report. So my findings are as follows. Samples collected for hospital lab and the clinical findings and all other additional observation. The first thing is sample for the forensic lab. So for the forensic lab and for the hospital lab. Now, treatment prescribed, if yes or no. For sexually transmitted disease prevention treatment, emergency contraception, wound treatment, tetanus prophylaxis, hepatitis B vaccination, post-exposure prophylaxis for HIV, counseling, and any other treatment. So, date and time of completion of examination. Again, in this format, date and time of completion of examination, this contains of the so many sheets and so many envelopes, so that if any tampering of the evidence or your report is done, then everybody knows that, because you have mentioned the number of sheet, signature of the examining doctor, name of the examining doctor, and place the seal. So no sheet can be removed because everybody knows the number of sheets. Final opinion. After receiving the lab reports in the following mentioned formats, the opinions regarding sexual assault survivor to be given in case of sexual assault. Opinion: there is evidence of recent sexual intercourse, remote sexual intercourse, or recent penetration. Conditions when such opinion is given: when recent injuries to the genitals and other body parts are found and motile spermatozoa recovered from the vagina. So it is evidence of recent sexual intercourse. Remote, when partially healed injuries and non-motile spermatozoa in the vagina. Recent penetration, local recent injuries to the genitals but no spermatozoa are recovered. Condom, vasectomized, finger, dildo or other objects may have been used. So all these can be recorded by you, and this will be very helpful for the forensics. Final opinion. next slide is opinions regarding the sexual assault survivor to be given in a case of sexual assault. There is evidence of remote penetration. There is evidence of recent sexual assault, evidence of remote sexual assault. There is evidence of vaginal penetration. So all these things can be recorded. How can it? The opinions can be formed when local or partially healed injuries to the genitals and there is no spermatozoa. There is recent evidence of penetration. When there are recent injuries, bite marks on the face, cheek, neck, breast, nipples, thighs, etc., but injuries to the genitals are absent, this means there is recent sexual assault. So, no injuries to the genitals, so there is no actual penetration. Evidence of remote sexual assault. Partially healed injuries. There is no evidence of vaginal penetration when there are no injuries and no spermatozoa are recovered from the vagina. Now coming to the next slide. Opinions regarding sexual assault survivor to be given in a case of sexual assault. There is evidence of recent oral or anal intercourse. When spermatozoa are recovered from these areas, there is evidence of remote oral or anal intercourse when partially healed injuries are noted and non-motile spermatozoa are recovered from these areas. Evidence of recent or remote oral or anal penetration when recent or partially healed injuries are found and spermatozoa are not recovered. There is no evidence of oral anal penetration, but possibility cannot be ruled out when there is no injuries and no spermatozoa recovered from the oral or cavity or the anal canal. So these various formats and these various specific language should be used while reporting. Findings in support of the above opinion, taking into account the history, the clinical examination findings, and the lab reports of bearing identification mark as above. So many hours or days after the incident of sexual violence, I am of the opinion that. So a descriptive finding can be given. Signature of the examining doctor, name of the doctor, place and the seal, copy of the entire medical report must be given to the survivor victim free of cost immediately. So summary is that there should be an informed consent per vaginal examination, two-finger test not to be done, hymen or size of vagina, etc. not to be commented, injury documentation should be done, sample collection and final opinion. So the following are the components of comprehensive healthcare response to the sexual violence and must be carried out in all cases. So the things which are important is consent, the age estimation, everything physical, dental, radiological, evidence collection, history, examination, treatment, documentation, discharge, and follow-up. So the injuries, together with the injuries, the sexually transmitted diseases test and prophylaxis, HIV test, emergency contraception, and counseling, everything should be done. So it should be very comprehensive. Now, sexual assault forensic examination kit. So, equipments should be, you know what the equipments are, and the torch, tweezers, scissors, nail cutter, comb, and measuring tape and calipers. The examination table should, and the well-lighted surrounding, there should be a wash basin and everything. Drugs and commodities, you should have everything. For prophylaxis, you should have the antibiotics, antiretroviral drugs, emergency contraception, analgesics, tetanus prophylaxis, pregnancy test kits and consent forms, the reporting formats and receipt for material evidence. Supplies for collection of forensic evidence. Everybody knows about this. You can take a screenshot if you want. Do you want me to read? I don't think you want me to read it. So you have everything with you, and you should keep it. If you don't have in your clinics, you should keep everything. So coming to the acknowledgement and references. So it was a detailed thing made by Dr. Ponuru Malathai, and the clinical examination is very, very important. As you know, after a sexual assault, the treatment part is also very necessary. Thank you all for the patient hearing, listening, and it is very informative, very important, though a very neglected subject, because most of the time the society and including us doctors may be neglecting some points, so we should come forward and deal with it on the front line. So thank you very much. So over to Kavita. What should we do now?
Yeah, thank you, madam. Thank you for your elaborate presentation. So now I think we should have some discussion. Dr. Nandini, do you want to discuss anything what has been written in the chat box, or we should go ahead for the test? We will appear for the post test immediately, na?
Yes.
Shriman, are you there?
Just don't exit from the Zoom. You wait
Yeah.
for some time and then the post-test screen
Yeah.
will
Yes, madam.
appear.
I think those who are present, please
Let Shriman
appear for the
explain.
post test. So wait
Let
for some
Shriman,
time. Yeah.
let
Wait for some
Shriman
time.
explain.
Yeah, Shriman?
Yes, madam. I'll
Yeah.
share you the link also in the group, madam. Just give me a minute.
Yeah.
I'll share the posters link in the group.
Yeah, yeah. Just to share so that we can appear for the poster. Those who are
You
present
just-
here, please appear for the poster. Then only certificates will come. So thank you everyone in this today's working day. And in spite of that, after a long vacation, Dasara, and many patients must be with everyone, but still many of you have joined. So I'm really thankful to all the participants who are here, and especially trainers, Dr. Nandini, Dr. Prema, and our own president, Dr. Rekhaja madam. They have explained very well. So really, I couldn't because really I was not aware of what I have to say. So I'm sorry for that. But still, this session is very informative, and what we have to learn how to deal such patient. If because we see these type of patient every day, so what we should do and how to make them less traumatic. That is the main aim, that we have to avoid the violence, whatever any woman faces, wherever she faces. So we have to avoid them, we have to prevent them. And if it happens, she should report, and she should get proper solution of that. So that is the aim of this Dheera program, Violence Against Women, and it should be started during adolescent period. Dr. Shanta Kumari madam has the idea that it should be at the school level, so that they have strength, they have courage, they develop courage to say no to violence against women. So really this is very important and very informative, away from our daily practice. This is one thing that we can do for the society, especially for our women, which we see daily that they have to face at the
Not we
home
can
as
do,
well as the
we have
workplace.
to do, we have to do.
Yeah, yes, really.
We
Thank
have
you,
to do in
Ashadi.
hospital also, in
Ranjana,
private also.
Ranjana, you want to say something? What you face at Katiyar? Ranjana, unmute. Yeah. Varsha is there.
Yes. Yes, sometimes I am facing so this problem, not always, not always.
Madam, I posted the link in the group, madam. Posters
Okay,
link.
okay, yeah, yeah.
Just click
So
on the link and you will be redirected to the post session feedback. You can leave the meeting. Just answer all the questions and submit, and you'll get a certificate within a weekdays.
okay, okay. Thank you so
Thank you.
much.
Thank
So
you, ma'am.
please, everyone should appear for the post test. Thank you so
Yes,
much.
ma'am.
Thank you, Sriman, for
Welcome, ma'am.
arranging in short period.
Thank you, ma'am.
Yeah. think everyone has appeared for the test.
No, I did not get the question is दीदी.
अरे तुम उसमें क्लिक करो, सुनो धीरा ऑब्सगानी पोस्ट टेस्ट लिंक है ना, उसको क्लिक करो वर्षा।
अब हो गया, उसके बाद क्या करना है? तो वो
उसके-
कहाँ पर है सर? वहाँ पे किधर मिलेगा वो दीदी?
देखो यहाँ चैट बॉक्स
में,
चैट बॉक्स
में. Oh, it's in the chat box. I was waiting for the question.
नहीं धीरा ऑब्सगानी पोस्ट टेस्ट लिंक का हुआ है, देखो ना उसको करो।
अब उसके बाद क्या करना है कविता?
अब तो हो गया। क्या रेखा मैडम, should we leave now?
अब भर के
Yes,
भेज
madam. After that you can leave, madam. After submission you can leave the meeting.
We should leave the meeting now. We are permitted to leave. Yeah. Okay. Thank you, Sriman, for arranging in such a short time.
सर्टिफिकेट कैसे मिलेगा?
मेल पे।
ओके।
You know what?
मैडम डेट याद रखिएगा, डेट
8 तारीख है, 8 अक्टूबर।
आप जो लोग अटेंड किया, रंजना याद रखना सर्टिफिकेट के लिए।
हमको तो दिखा ही नहीं का क्वेश्चन है
यार, ये चैट बॉक्स में जाना है।
कहाँ दिख रहा क्वेश्चन? हम तो
नॉट गेटिंग द क्वेश्चन।
देखो यहाँ दिए, देखो
लिंक है चैट बॉक्स में।
नहीं आ रहा है।
इसको करो ना क्लिक, इसको करो जो हम किए हैं। देखो मेरे
हमारे तो दिख ही नहीं रहा है, मेरे भी तो दिख ही नहीं रहा है।
ऑब्सगानी पोस्ट टेस्ट लिंक
चैट बॉक्स पे कहाँ
हेलो,
वो तो चैट बॉक्स ही नहीं में आ नहीं रहा कुछ मेरा।
तुम्हारा चैट बॉक्स नहीं खुला है। मधु सिंह हैज रेज हैंड।
Have you received the answer?
Madhu di,
The answers which we have submitted, have you
want
received?
to say something? Madhu di.
Yeah, thank you very much, Kavita, for
thank you,
messaging
Dee.
me to join. And it was very nice webinar.
Okay.
And it was very
Thank you, Madhu di.
informative also. And
Okay,
it was
thank you.
also informative.
थैंक्स टू ऑल कविता, थैंक यू।
Last question, I was disconnected because due to net problem.
Okay, all right. Oh, कोई बात नहीं। Thank you दी। Thank you and good night.
Good night.
Hello, Kavita.
हाँ जी, hello.
Hello. It was a nice program, Kavita.
हाँ,
And
thank you.
whatever we have submitted, has it reached Mr. Shriman?
I think अगर आपने वही रेस्पॉन्स ये खुद से चला जाएगा ना सिस्टम।
हाँ, मैंने सबमिट कर दिया है।
Kavita,
हाँ
we will
जी
get
मैडम।
certificate.
प्रणाम
We will get the certificate through email. Email से मिलेगा certificate.
हाँ
खुश हो।
प्रणाम।
हम लोग पीएमसी वाले लोग मिल गए ना
तुम लोग को देखकर।
हाँ, अब भागलपुर आएगा तो और मजा आएगा। आइएगा, मधु दी आ रही है।
एकदम मतलब बहुत ईगरली वेट कर रहे हैं।
बिल्कुल। एमजीएम मिनट वाले लोग, हम लोग एक साथ फोटो खिंचा लेंगे। एमजीएम आ रही है, मैडम आ रही है ना। मधु दी,
विनीता जी को भी बोलिए दीदी, विनीता जी को भी बोलिए आने।
हाँ मधु दी बोलिए।
विनीता जी को।
हाँ विनीता को भी बोल रहे हैं आने के लिए।
हाँ, आप लोग
मोतिहारी ना,
हाँ
मोतिहारी वाली विनीता ना।
हाँ
बोल रहे हैं, उसको भी कहते हैं चलने के लिए।
सबको बोलिए। देखिए बहुत रेट नहीं बढ़ा है मधु दी, हमारे हिसाब से बहुत ज्यादा रेट नहीं है, इसलिए थोड़ा रेट बढ़ भी गया तो कहीं लोग करेगा रजिस्ट्रेशन और आएगा, है ना।
एकदम ही रेट नहीं है, नहीं।
ठीक है,
अरे रेट से कुछ नहीं होता है कविता।
हाँ बिल्कुल, दिल से मिलना है, बिल्कुल।
मतलब हाँ, और अपडेट भी तो हो रहे हैं ना, बहुत सारा आज भी अपडेट हुए हैं। आज भी बहुत सारा अपडेट।
ये तो है।
रंजना
मिला। हाँ बस उसको तुम भरते जाओ कहानी।
ठीक।
लास्ट में तुम सबमिट कर देना।
पोस्ट वाला मतलब प्री तो भर दिए हैं, पोस्ट भी भरना है।
मधु दी भरी है, हाँ तभी सर्टिफिकेट आएगा। पोस्ट देखिए यहाँ चैट बॉक्स में दीदी, मधु दी। हाँ चैट बॉक्स में ना लिंक, उसी को बस क्लिक करिए, एक बार क्लिक करिए आ जाएगा। और भर के उसके तभी एग्जिट कीजिएगा, अभी एग्जिट मत कीजिएगा। उस पोस्ट में पेड़ होके तब
कुछ आ नहीं रहा, क्या लिखना है?
क्वेश्चन आएगा दी, क्लिक कीजिए ना उस पे, लिंक पे क्लिक कीजिए।
उसको लिंक को क्लिक करिए, क्वेश्चंस आते रहेंगे। कुछ तो पहले ही वाला है, पहला ही क्वेश्चन सब कुछ है, बाद में कुछ एक्स्ट्रा है।
इसमें तो सिर्फ चैट वाला में बोल रही हो।
देखिए लिंक है, देखिए है ना, धीरा ऑब्सगानी पोस्ट टेस्ट लिंक। देखिए दीदी लिखा हुआ है धीरा ऑब्सगानी पोस्ट टेस्ट लिंक, इसी को करिए।
हाँ।
ठीक है, उसको क्लिक करिए, सारा क्वेश्चन आता जाएगा, उसको करके सबमिट कर लीजिएगा, तब फिर छोड़िएगा। ठीक है,
अच्छा ओके।
ठीक है दी, नमस्ते। बहुत अच्छा लगा आप लोग ज्वाइन कर लिए तो हम लोग
अच्छा लगा, हमको भी अच्छा लगा।
हाँ चलिए। मैडम रेखा मैडम।
हाँ बोलो।
हाँ, अब छोड़ सकते हैं, एक दो मेरी पेशेंट वेटिंग है, देखें क्या हालत है।
हाँ हाँ बंद करो ना, हम तो तुम लोग का सुन रहे थे बस, हमको शिवानी झा का फोन आ रहा था,
अच्छा ठीक
वही
है,
सब